join us today. And I'm sure we all have a copy of the agenda. We're starting a bit late already, but as we wait for others to arrive, we have to start off. So we want to welcome Mr. Uche Ebele. He is the country manager for Sysmex West and Central Africa, to give us the welcome remarks.
Good morning, Prof. Good morning, everyone. It's with great delight and honor that I welcome you to this very special program. As you said, my name is Uche Ebele, the marketing manager for Sysmex Nigeria. And this morning we are looking at a very critical aspect of patient management. Population issues are critical for all categories of patients, particularly surgical and all. So this morning, the specialists are here. We on the other side is the industry that have produced and provided the platforms for you to use to manage patients as well. So this meeting point is very critical for us, and we want to thank you especially for honoring us with your presence. I want to ask you to relax, enjoy, and interact. It's from these programs that we have innovations coming from the users to inform industry. So whatever we want the industry to begin to think about, it is from such forum that we innovate, because we've gotten feedback from you. So again, on behalf of Sysmex and Uni-medical Healthcare Limited Nigeria, I warmly welcome you and ask you to sit back and enjoy. Thank you.
Thank you, Mr. Still on introduction, I have to introduce myself. My name is Jane from Haemostasis. I'm the product specialist for Sysmex West and Central Africa. I will be moderating the program for today. So feel free to relax and enjoy the flight. So the next on the agenda will be calling on the first speaker to give us a presentation on the Haemostatic Disorders and overview. So first of all, I have to read her citation. Professor Ebele Uche is a consultant hematologist and present head, Department of Haematology and Blood Transfusion, LASO. She holds a fellowship in Haematology and Blood Transfusion from the National Postgraduate Medical College of Nigeria. She also holds other degrees and certifications from various organizations. In the course of her career, she has worked in various organizations, both public and private, and has undergone several international trainings in transfusion and transplantation medicine, as well as in sickle cell. She is the recipient of several awards and grants, with the most recent being a training grant from the European Union for sickle cell management, which saw her visiting several illustrious hospitals in the United Kingdom to get hands on training in various aspects of management of sickle cell anemia. She has also received a fully funded grant for training in hematopoietic stem cell transplants at the University of Illinois, Chicago, USA. Professor Uche is a member of various national and international professional bodies. She has attended numerous scientific conferences where she has presented some of her research work. She is involved in teaching undergraduate and postgraduate hematology and blood transfusion, HIV medicine, and has supervised several postgraduate residents and sessions for National Postgraduate Uni-medical College of Nigeria. Professor Uche has over 80 research papers published in both local and international peer-reviewed scientific journals. Please join me to welcome Professor Uche.
Good morning, everybody. It's really a pleasure to be here this morning, and I'm grateful to the organizers for inviting me to speak on this very important topic. I know that we have a very mixed audience here. At least I recognize a few of my esteemed colleagues, fellow hematologists, and I know that we'll have other clinicians, laboratory scientists, maybe nurses and all. And so I've tried to keep the presentation as simple as possible so that we can all understand, and that at the end of the presentation we go home with something. Now, hemostatic disorders, even for those that are doctors, even in medical school, most of us hated coagulation because we just felt it was a whole bunch of factors. We just felt, oh, you have to cram the factors. Factor 2 will activate factor. So it was it was a very it was a topic that I mean I don't know about everybody else, but for me as a medical student, I hated coagulation, and I was so happy when I passed pathology and pharmacology. I didn't know that I was waiting to enter into the mainstream coagulation when I went in to do hematology as a resident. But I want us to understand that if you understand the basis of coagulation, then it's very easy to build on that foundation, and you will be better able to make a diagnosis in your patient. Okay, so this is my outline and introduction, etiology, predisposing factors, the symptoms, laboratory diagnosis, very importantly, and management. Now, whatever it is we say about coagulation, the main aim of coagulation is to ensure that when we have an injury, so for example, you are a man or a woman, you are in the kitchen, you are cutting up your vegetables, and you mistakenly cut your finger. Okay? So the aim of coagulation in that instance is to make sure that you do not bleed out. Because if coagulation does not occur, if the factors that will lead to the formation of a clot, if they do not come into play, most of us would have bled out a long time ago. So the major aim of coagulation is to ensure that when there is an injury, I think it's better. So the major aim of coagulation is to ensure that when there is an injury, the body is able to ensure that a clot is formed. And whatever it is that happens, that is the end result. The formation of a blood clot, or like we say in hematology, polymerized fibrin. So that is one arm of what coagulation aims to do. And then the second most important part of coagulation would be that when that clot happens, right, and the vessel wall is repaired at all, the aim of hemostasis is to ensure that that clot is broken down. So it's not just enough to form a clot. If there's an injury to a blood vessel, there's bleeding, the various factors come into play, there's the formation of the clot, which is the polymerized fibrin. But then the next step will be to ensure that when the clot has done its work, the body is able to break it down, which is fibrinolysis. And so you see that there's a very delicate balance between bleeding and thrombosis, right? Thrombosis just means the clot, okay? And so God is wonderful. We see His ways in so many things. And then in coagulation is very interesting that you are not just sitting down and your blood just starts clotting because of various factors that we all have as human beings. Now, when we want to talk about coagulation or hemostasis generally, there are three factors that are important. There's the role of the blood vessels, there's the role of the platelets, and then there's the role of the coagulation factors themselves. Now, if any of these factors are lacking or are deficient or are abnormal, then that patient would likely come down with a bleeding problem. Because in order to form a clot, the blood vessels are involved, the platelets are involved, and then the coagulation factors are involved. And so hemostasis is just the body's natural process of stopping bleeding after damage, like I said before, and then also ensures that when that blood vessel is repaired, the that clot that has been formed dissolves. And so the blood vessels, I mean, because we're a mixed audience, I'm not going to go too deeply into, the pathophysiology and all, but it's important for us to note that the blood vessels have their roles to play, the platelets have their role to play, then the coagulation cascade and the fibrinolysis. So the blood vessel and the platelets will form what we call the primary platelet plug. Now, this primary platelet plug is a very delicate plug. It's a very friable plug. And so that is why when you have an injury and it forms a clot, if you dislodge that clot immediately, that injury will start bleeding again. Because all that your body has formed is a primary platelet plug. For hemostasis to be complete, your body needs to form a secondary plug. And so that is when on the blood vessels and the platelets that are formed the primary platelet plug, the coagulation factors come into play to form your secondary platelet plug, which ends with the formation of fibrin that is now polymerized. So when you say somebody has a clot, what you are saying is that that person has polymerized fibrin. The body has formed polymerized fibrin. Of course, fibrinolysis simply means the clot has been formed, the vessel has stopped bleeding, everything has gone back to normal. That clot is now dissolved. Now, hemostatic disorders, like I said, on one hand you have the bleeding disorders, on the second hand you have the thrombotic or the clotting disorders. Okay, bleeding disorders typified by the hemophilia. So the hemophilia A, hemophilia B, hemophilia C. Okay, those are the congenital ones. Of course, you also have the acquired bleeding disorders. So, for example, a patient that has low platelet count for any reason, okay? So, a patient has a platelet count of 10,000, 5,000, that patient is likely to bleed. So, those are acquired bleeding, those are commonly acquired bleeding disorders. Or a patient that is on aspirin, for example, because we know the role aspirin plays in platelet function, that patient may have a bleeding disorder. And so all those things come into play, especially when you're faced with a patient that, for example, is going for surgery and such patient has been on aspirin. It is very likely that patient is going to bleed. Ideally, if you have the luxury of time, with the knowledge you have that, an aspirin causes a platelet dysfunction, that is usually reversible. But you also know that the patient needs to be off aspirin for at least 7 to 10 days. Okay? So those are the things you need to take into consideration. If it's an elective surgery, of course you have the luxury of time. Tell the patient to go off your aspirin and then come for the surgery. Of course, if it's an emergency and you really need to do that surgery, you don't have that luxury of time, then there are other things that you could do. So there's the bleeding disorders versus the thrombotic disorders. Okay, so the thrombotic disorders, commonest would be the venous thromboembolism. We're going to talk a bit about them more later. And then, like I said, there are large hemostatic disorders are largely either misdiagnosed or underdiagnosed. Reason being that a lot of us in the healthcare system, whether we are laboratory scientists, whether we are doctors, the index of suspicion is usually very low. And in this part of the world, a lot of people still tend to do symptomatic treatment. So a patient comes to you bleeding with a platelet count of 10, 12,000. We see them a lot in LASO. Okay, so all the doctor is doing, the doctor just keeps ordering for platelet concentrate, ordering without trying to find out why that patient is bleeding. And so it's important that one of the things we should take back from here is don't just treat the symptom. For the patient to be bleeding, there must be a reason why that patient is bleeding. And so that is why in our environment, our statistics are not so good because a lot of times these clinical conditions are largely underdiagnosed and also misdiagnosed. And of course, diagnosis is also difficult because of lack of diagnostic facilities. especially in hemostasis. Okay, I mean, doing a full blood count, it's very easy. Everybody will do a full blood. But when it comes to things like platelet function tests, for example, you have a patient that is bleeding, right? And we'll talk about the patterns of bleed and how they would help you know what is the most likely cause of that bleeding. So if you have determined that this bleed is due to a platelet problem, okay? So a platelet problem could either be a qualitative problem or a quantitative problem. If it's a qualitative problem, a full blood count will be able to show you, oh, you do a full blood count, platelet count is 5,000, 10,000. But if it's a qualitative problem, it becomes a bit more tricky, right? Because we usually say do a bleeding time. But as hematologists, I'm sure my colleagues will agree with me that the the objectivity of the bleeding time comes into question. Okay, because bleeding time has to do with the expertise of the person doing it, has to do with the method. And so ideally we should be doing platelet function analysis. And as at the last time I had it, I still have that problem. I have a woman that is bleeding that I suspect has a platelet dysfunction, but I really am still not able to make that because nobody does the PFA analysis in Nigeria. Dr. Ware, I think I even reached out to you to show you. I reached out to all the labs that I knew just to see if we could help the woman in any way. I ended up putting her on prednisolone because I know prednisolone means people will share of their medicine. But it's most so her platelet count actually started going up. Okay, so diagnosis is also a very big challenge for us in Nigeria. So bleeding disorders, like I said, there are three major factors that are involved: your blood vessels, your platelets, and your coagulation. So vascular disorders, inherited or acquired, simple things like scurvy, vitamin C deficiency, especially in the elderly, right? They will say, oh, when I brush my teeth, my gums bleed. And so it's important to us as clinicians that when we are faced with patients, common things occur commonly. In medical school, one of my professors always used to say to us, when you hear hoofs, think of horses rather than donkeys, meaning that the common things will occur commonly. So you are faced with a patient, rather than thinking of the high falutin things, start from the bottom. And sometimes you will even be surprised that just giving this patient vitamin C, you have helped that patient. Okay? So the thrombocytopathy, those are the platelet dysfunction. It's here that we have, Dr. Ware, have you found a solution for us? This is where you found a solution. C-Lab has found a solution. So this is where we have an issue, making diagnosis of this, okay? And then of course the defective coagulation, the inherited or the acquired. So these are the classifications of bleeding disorders. I told you the blood vessels, the platelets, and the coagulation, right? I just briefly told them, reaching out a few examples. Okay? Now, it's important, like I said, when you are faced with a bleeding patient, the first thing you need to determine is what is the likely cause of this bleeding if you think that patient has a bleeding disorder. And the pattern of bleeding is what is going to help you first as a clinician. So, bleeding that is usually due to platelet disorders or blood vessel problems, they are usually these superficial bleeds. And so they are the ones that will have the petechiae, the ecchymosis, the purpura, the gum bleeds, or mucosal bleeds. But the coagulation factor deficiency bleeds, they usually cause deeper bleeds. So they are the ones that will have the hematomas, the hematosis, and all. A patient that has a coagulation factor deficiency is unlikely to have purpura, petechiae, and ecchymosis because those bleeds are due to either a blood vessel problem or a platelet problem. Of course, there are exceptions. The patient has a convict ground, for example, where platelets are also affected. Such a patient can have a superficial bleed. But as a rule of thumb, we usually say that the superficial bleed would indicate that this patient has more of a platelet and a blood vessel problem, and then the deeper bleeds would say that the patient has more of a coagulation factor problem. And then this is what also is quite important to us as clinicians: your petechiae, the purpura, and a diagnosis. Usually it's just it's about the size, less than 2 millimeters, 2 millimeters to 1 centimeter, and then more than 1 centimeter. Okay, so because we said that these bleeds are usually superficial, you have the skin bleeds, which are the vertical purpura ecchymosis. For women, you would have menorrhagia, you would have the gum bleeds. If there are coagulation factor deficiencies, you would have haemostasis. Sorry, I need to put water. Okay, and then in severe cases, you can have intracranial bleeds, and that is where we do not want to go to having an intracranial bleed. So these are just some of the clinical presentations, haemostasis. Okay, so we now come to thrombotic disorders. Okay, now the way, like I said, the way nature has made it, a blood clot is not supposed to form within an intact vessel. If not, all of us will be walking around with thrombosis and embolism. Okay, so it's the formation of a blood clot within a vessel. This vessel can be an artery where it's called an arterial thrombosis, or it could be a vein where it is called a venous thrombosis. So typically, the arterial thrombosis would lead to clinical presentations of myocardial infarction, the cardiovascular accident, that is a stroke. While for those of venous thrombosis, patients will come with deep vein thrombosis, and if there's a dislodgement of that thrombus or clot. So remember that anytime we say thrombus, it's just a clot. Thrombus is a clot, okay? So if that thrombus dislodges and goes to the pulmonary vasculature, it becomes a pulmonary embolism. Now, the risk factors for arterial thrombosis, most of these risk factors are risk factors that are related to development of atherosclerosis. So whatever risk factor that you think would lead to atherosclerosis would also be a risk factor for arterial thrombosis, okay? I think this is all very technical, so I can leave that out. Positive family history, very important. Males, hyperlipidemia, and so there are so many risk factors that can be associated with arterial thrombosis. And I'm sure if we go through all this list, everybody here has at least one risk factor. So it's either you are a male, you have a positive family history, you are on lipid lowering drugs because of hyperlipidemia, antiphospholipid syndrome, hypertension, diabetes, gout, polycythemia. So the list is quite long. Cigarette smoking, lupus antibodies, the list is quite long. And so it's very important as a way of prevention of arterial thrombosis. Clinically, when you are assessing the patient clinically, it's important that you identify the patients that are at risk of developing an arterial thrombosis. And research over years has come to give us some, the way you can assess. You can now have the coronary artery thrombosis risk profile. And so you have a patient seated with you. There are different parameters based on age, sex, blood pressure, and all. And at the end of it, you are able to categorize your patients. High risk, moderate risk, low risk, okay? And based on that risk classification, you're better able to advise the patient. And most times, lifestyle, if you look at most of those factors, one thing that can address all of them would be what? Lifestyle modification, okay? And that is why I'm sure recently we've been hearing stories of young, apparently healthy people walking on the road, slumped to die. Okay, because they basically have risk factors that have not translated to clinical signs and symptoms yet. Okay, and so that is why, again, it's important that yearly, as you get older, Nigeria on its own is a risk factor. Even in Nigeria is a risk factor for so many diseases, right? So as we get older, especially for those of us that have hit 40, please every year take out time and do a general check. You know, it doesn't have to be the highfalutin general checks. A full blood count, a lipid profile, a blood sugar. You know, do the basic things. Check your kidney function, check your liver and all. Because by the time you're able to do that, you can see that you've almost basically assessed your risk for having a coronary artery thrombosis. Okay? And then based on whatever results you get, you can now institute the right changes. And this risk assessment allows for pre-symptomatic assessment of young and apparently fit subjects. And so I'm sure that and again, Nigeria is a country where if you tell the patient's relative, please let's do a post-mortem. They committed a crime. Okay, but I'm sure that in countries where post-mortems are done, sudden death is an indication for a post-mortem. And I'm sure that if we do post-mortems on some of these people, you will see that most of them would have one or two of these risk factors of arterial thrombosis. Okay? Okay, so this is just a diagram. So we'll come to the venous thrombosis. Now, again, I said venous thrombosis simply means that the clot has formed in a vein. And the clot usually forms in the deep muscles of the veins of the lower limb, very commonly. Occasionally, they can form in the upper limb, but almost all the cases of deep venous thrombosis that we see in clinical practice are usually thrombosis of the lower limbs. Okay, and then in some cases, this thrombus can break free from where it has formed and then travel and goes to the pulmonary vasculature. So in that case, you see that the thrombus has embolized and the patient no longer just has a deep venous thrombosis, the patient has a pulmonary embolism because the thrombus has gotten into the pulmonary artery, whether the main pulmonary artery or one of its collaterals. Okay, and again, it's one of the very common causes of sudden death, massive thromboembolism. So when we say venous thromboembolism, we mean both a deep venous thrombosis and a pulmonary embolism. Okay, I hope you are following it. I made it quite simple, so it's very easy to understand, right? Okay. So epidemiology, again, the true incidence is unknown. A lot of times, a deep venous thrombosis can actually go undiagnosed because we've had patients that suddenly just come to you with a pulmonary embolism. And there's no way a patient will have a pulmonary embolism without having a DVT. It's not possible. The only way a patient will have a pulmonary embolism is that a thrombus has formed in a deep vein and it has embolized. But a lot of times, that DVT has gone undiagnosed. The patient will not have any symptoms. Am I correct? Yeah. A lot of patients, well, not say, but quite a number of patients will not have any symptoms of a deep vein. So the classical calf pain, calf swelling, cramp, even when you ask them, they'll say no. Okay? And so a lot of times it goes undiagnosed. For the patients that are lucky enough to be alive, but for a lot of patients, they don't have that luxury. So they have a DVT, they're walking around with a DVT. They don't know. And then the next thing they collapse. Why? They've had a massive pulmonary embolism. And for some patients, that is the end of their journey on earth. So it is the third commonest cardiovascular disease after a cerebrovascular accident and myocardial infarction. Nigerian statistics, now these statistics are post-mortem statistics. So it's statistics that we got from doing post-mortem. Like I said, because we don't do post-mortems on everybody, I'm sure this figure is grossly underrepresentative. So we have the 2.9% male versus 2.6% female prevalence post-mortem data, and I've put my source there. Okay? Pardon me? You said? Okay, so very quickly, again, I won't go into this, it's more of technicality. There are three major reasons, three factors that come into play before a thrombus is formed, which is called the virtuous triad, named after the man that discovered it: stasis, vessel wall injury, and hypercoagulability. So that means anything that will make blood flow, the rate of blood flow reduce, anything that will damage your blood vessel wall. And then, of course, with stasis, stasis will actually also lead to hypercoagulability. Okay? So I'm going to put a diagram here. So that's a table to show you these three different factors that are involved in the formation of the venous thrombus and some causes. So, for example, hypercoagulability, you will see that in patients that have had a major surgery or trauma, patients that have history of malignancies, pregnancies, when it comes to vascular damage, cellulitis, atherosclerosis, even the presence of a central line. But we've actually had patients that have developed deep venous thrombosis after a central line insertion. So even the presence of a central line, because it would cause damage to the blood vessel, can be a risk factor for, I think my time is almost gone, can be a risk factor for a venous thrombosis. Okay, so when it comes to venous thrombosis, the risk factors, they can either be inherited factors or they can be acquired factors. Inherited factors, you don't have any control. That's the way you were born. So those are the common inherited factors, protein C, protein S, and all that. Again, challenge to diagnostics for most of our patients that we need to send for screening for inherited hemophilia. So all these things are come under the group of inherited hemophilia. We still need more diagnostics in this regard, okay? Then these are the acquired one, malignancies, surgery, and all. And so, for example, in malignancies, that is why when you see a patient for the clinician, when you have a patient that has the cancer, you should evaluate the risk of a venous thromboembolism in that patient. And there are various scores, but I think the coroner score is commonly used. So pregnancy on its own is a risk factor. We've had pregnant women that have had deep venous thrombosis. Also, women on oral contraceptive pills, postmenopausal women that are on hormone replacement therapy, or maybe men that have been managed for one of those cancers or tumors. Immobilization is very important. Patient is sick and is admitted in the hospital, is unable to mobilize for 2-3 days. So it's quite important for those category of patients, you may consider putting them on prophylactic anticoagulants. Okay? So these are all the other risk factors. Remember that most of these other ones are the acquired risk factors. Okay? So the clinical presentation, like I said, lower limb deep venous thrombosis, pulmonary embolism are the two manifestations of venous thromboembolism. Accurate diagnosis is important. I always say to people that it's better to anticoagulate that patient therapeutically, especially if there are no contraindications, okay, and especially when you weigh the risk of bleeding and risk of thrombosis. If the thrombotic risk is higher, even before you get a diagnosis, it's safer to anticoagulate that patient, because the delay in commencing anticoagulation could actually lead to the patient's death. Like I said, the features of a DVT may be non-specific. So patients may not even have any features. Okay? Many patients are asymptomatic. And so you must have a very high index of suspicion, because the risk of untreated DVT may be fatal. So suspect DVT patients that present with neck swelling, pain, warmth, and so any patient the patient comes to you has especially unilateral leg swelling, okay, the place is warm and all that, always suspect a DVT, okay. Very occasionally a DVT can be bilateral, most times it's unilateral, and all that. So I've gone through, I think the slide will be made available just for us to write time. So of course it's always important to take a very, very good history, family history, especially a history of recent travel, but a lot of times the patient will give you that history that, oh, I just came back from a 6-hour trip, okay? Lifestyle, is your job sedentary? Have you been ill? Have you been on admission? Take a very good history. Of course, also your history should also include things that will point you to the presence or absence of the acquired risk factor in the patient. So you examine the patient, check for the veins, check for the swelling. Of course, when you're checking for the swelling, you have to be objective. You measure the two limbs in order to accurately say that, oh, there's indeed a swelling and there's a difference in the circumference. Okay, so one very good thing that helps us as clinicians in order to determine the probability of this patient having a DVT is what we call the Wells score. And so you go through the Wells score and you total it, and you can see that if it's less than 0 or 0 is low, you have your moderate probability, you have your high probability. And so with this will now inform your management of that's index patient. Same thing. So there are different scores, but the popular ones are the well scored, there's the Geneva score, there are various other scores that I use. This is just a picture. Pulmonary embolisms. Now, I mean, DVT on its own, it will just probably cause a discomfort, pressure and all, but this is where we do not want the patient to go to. And unfortunately, you can't predetermine which patient has it, which of the patients with the DVT will get a pulmonary embolism. Okay, and so the patient comes to you with dyspnea, chest pain, cough, tachycardia, and all that. I think we're mixed on and so. So again, you also have a scoring system that helps you determine whether this patient actually has pulmonary embolism. These are the symptoms, clinical features. Okay, so let's now come to diagnosis of bleeding disorders, which is a very important part of why we are here. Now, like I said, the hemostatic disorders could either be the bleeding disorders or the thrombotic disorders. When it comes to the bleeding disorders, I mean, as a hematologist, I will always say, if you don't do any tests with the patient, do a full blood count. Even if the patient comes to you and you feel that, oh, this is not hematology, at the very least do a full blood count, okay? And of course, if you're thinking this patient has a bleeding disorder, which we have said might either be due to a vascular problem or a platelet problem, you are interested in looking out for the platelet count of the patient. So does this patient have a low platelet count? And the normal platelet count we have said would be, normal platelet count would be, okay, okay, so even though most literature will tell you 150, but Nigerian hematologists, 100,000 is fine. Okay, and then they put through platelets that platelets have a very high threshold, meaning that you can see a patient that has a platelet count of 10,000, and that patient is walking around. Okay, and so that brings us to the point that it's not all patients that have thrombocytopenia that you should be giving platelet concentrate to. Very important, because we see a lot of referrals. Oh, platelet count was 60,000. We gave 5 pools of platelet. In fact, not only have you not helped that patient, you have actually, what's the word? Apart from wasting, you have actually put the patient in more problems, because most of the platelets we get are concentrates from different sources. And so what you have done is that you are increasing the risk of what? Refractoriness in that patient. And so the patient, you are pumping platelets into the patient's platelet count is not growing up. So usually we would say the threshold for, in fact, in some guidelines, the threshold for transition is 10,000 for platelet transfer. Of course, there are caveats to that. If the patient is already bleeding, whether the patient has a count of 20 or 30,000, you should give. So those are, so when you see a patient that you think has a bleeding disorder, the full blood count is important. The full blood count, the automated count will show you the count, and we've agreed now, as Nigerian hematologists, we usually accept counts of 100,000 and above. Even though doctor, hematologist people who disturb us in lawsuits, present platelet count is 110,000. The patient has thrombocytopenia, we cannot go to the theater. Go, sir. You can neurosurgery, the cutoff is 60,000, 80,000. You can go, sir. But most times they just want you to just put your signature there, so that in the event that things go south, they will come and carry. Okay, so you want to see what the platelet count is, and then I always say, as a hematologist, you can't be doing a full blood count without doing a peripheral blood flow, because we have a lot of times they say, oh, this patient has thrombocytopenia. You look under the microscope, there are platelets everywhere for so many reasons. Number one, the platelets may be clustered, clumps, okay? And so you may see like a clump of like 100 platelets. And the machine, remember that the automated machine, they count the cells based on mostly their sizes. Okay, so when you have the platelets, you have large platelet clumps like that, the automated machine will automatically tell you that you have a thrombocytopenia. But when you look under the microscope, you can see that this patient has a lot of clumps. And by the time you're seeing a clump of platelets you see a clump that has like 20 platelets. And we know that approximately one platelet we see is about 20,000. So that means in that clump alone, you're having almost 400,000. Okay, so that's why a peripheral blood flow is important, so that you don't waste the patient's money doing high-value investigations. So for us in our clinic, as a rule of thumb, once the patient comes, no matter the scenario the referral letter has painted, we must still do a full blood count and a blood film before we agree to register the patient. Because so many times we've seen that, oh, platelet count is 30,000. And then sometimes even the anticoagulants you use, some patients have EDTA dependent antibodies. And so when you do their count using EDTA, you would have a thrombocytopenia. But when you change the anticoagulant, maybe you use lithium heparin, you will see that the platelet count normalizes. Okay? So, and then some patients will have what they call platelet satellitism. So rather than the platelets being separate, they just go around a neutrophil. Okay? So in that case, your automated count will tell you that this patient has a thrombocytopenia. When you look under the microscope, you know, this you see. So that's why we encourage all those that are running laboratories, please inculcate that habit of looking under the microscope. Okay? Then bleeding time. Again, bleeding time is a test that can be done by the bedside to assess primary hemostasis. Primary hemostasis is the role of platelets and the blood vessels. But this is it can be a very subjective test if not properly done. Because number one, the most important thing that will give you a good outcome is the expertise of whoever is doing it, right? And then, because when you actually want to do a bleeding time, I see that a lot of us, when we do bleeding time, we just use a needle, right? But there are specific lancets that are made for that. And the lancets are made in such a way that the depth of the needle is already predetermined. Unlike using just a blindly. So I can go in this far, somebody else will go in this far. But if you use a specified lancet, it already has a predetermined depth. And so you go in and then you do your bleeding time. Okay, and the bleeding time will let you know, oh, this patient's bleeding time is good. The normal bleeding time should be 2 to 8, some people would say 10. Okay, and you know, it will help you say, oh, this patient probably has either a vascular problem or a platelet issue. And of course, there are other tests, the health tests. And so this is where I'm going to, this platelet function analysis. Is there any lab in Nigeria that does platelet function analysis? No, but that, or is it not important for us? It is. Dr. Davis, it's not important. Very important. Okay, so that is one of the challenges we are throwing out today. We need platelets analyzers. There actually used to be, you have, yeah, I heard that there's one that they put in one, which hospital was that? Okay, you know, yeah. PFA 100.
No, for I don't think we have PFA.
So why can't we? Is there what are the
yeah, CN 660 CN 1600 even has more than this PFA.
Okay, so where is it?
It's not in Nigeria.
Why? What are the limitations? What are the limitations? What's preventing it from coming?
One of them is the cost, maybe.
Yeah.
But we can discuss
This
that.
my oga.
but we have instruments that can do all of this. Yes. Thank you.
It would go a long way. I'm sure the worst case I'd like to see is bleeding disorder, because making a diagnosis can be very, very stressful. And the patient, like I have one woman now, she comes in from Kano with 4 years ago, we don't know what's wrong with her. And when she's bleeding from her nose, from her ears, she's bleeding from her vagina. They've done a total abdominal hysterectomy for her. Because of that, she's pouring. Nobody knows what we've done, everything within the limits. We put her on prednisolone for a while, sugar went up, now we are struggling with that. So it has been this, and she can't afford to go abroad because those kind of patients, you just tell them, madam, please go abroad and get evaluated properly. Okay, so please, I think Dr. Ebele is okay, so then the ones that are available to us, the prothrombin time and the APTT, we still need the automated ones.
Yes.
I'm telling my order. Because we don't want to be mixing things anymore. We need and then factor assays. Okay? I think I've seen a coagulation equipment that does all the coagulation screening tests and also does factor assays. We used to have one in use.
I think it was still Sysmex, modulated by HFA.
Is it still in use?
Yes.
Okay.
But
It's working on one leg. This is small one.
It's a small one, yes.
So please, if we can get those, because it's we shouldn't have to be. If I said a factor assay is similar, how many days?
7
That's a lot.
7 to 10.
This everybody says everything now. Cleaner Lancet is even worse. 3 weeks. I don't think there's any test you can get before. So everybody, so I'm wondering what are the limitations? Why are we not having? We are not going in SynLab now. So why can't the machine be put in Lagos?
Well, I think most of the time it's actually getting to convince the board. Because again, it's all about the volume. Yes. Really get that.
So, but your PT and BTK is done in-house.
Yes.
Okay, it's just the factor assay.
But the factor assay, you can actually run if you're able to run PTT, you should also be able to run
So you should
factor
get a
assay.
machine that you can actually do.
With the semi-automated, don't just need this, just the APTT agent and calibrate. Yeah, if the Sysmex is still what the semi-automated, still what you use. Just to get the expertise and then.
Yeah, then the reagent will also need the factor.
You need the factor deficient.
Yes, but it's a big lab.
It's a very big lab, okay? So after the diagnosis of bleeding disorders, you need to ascertain the nature of the bleeding. Is it inherited? Is it unacquired? Is it a vascular uptake? Because this is the most important part. You need to be sure that you need to answer the question: is it a vascular platelet or is it a coagulation? Then you perform your screening test. Screening test will be the full blood count, peripheral blood film, bleeding time, prothrombin time, and the APTT. Okay? Then of course, depending on the results of your screening test, you can now perform specific tests and that will give you your diagnosis. So I have the table here. It will tell you if your whatever time, the bleeding time is prolonged, this the platelet count is normal, this. Okay, so that's just an approach. So diagnosis of thrombotic disorders, clinical history and examination is key. So if you want to make a diagnosis of a DVT or a pulmonary embolism, a full blood count might not be helpful for you for diagnosis. It may help you to determine maybe what the cause is, when you want to talk about treatment and all, but it must depend on your clinical history, the history and the examination. But one of the tests that will be very useful is the D-dimer test. In all cases of venous embolism, D-dimer is elevated. D-dimer is it's a very sensitive test, but it's not specific. So there are so many other reasons why D-dimer will be elevated. In our clinic, we have so many referrals. D-dimer is this, D-dimer, and we keep saying it's not all cases of elevated D-dimer. And it's something we can all do as clinicians, and so not jam our clinic, just do their well score. Okay, so if in doubt, use the well score. So D-dimer, even though it's very sensitive, meaning that it would pick up all the true positives, is not very specific. Because for example, a pregnant woman would have an elevated D-dimer. A woman that is on oral contraceptives would have an elevated so this is again where we are going to when you want to screen for the inherited hemophilia. So, for example, you have a patient that has a DVT, you've treated, repeated your imaging, everything has gone. So you stop your anticoagulation. 6 months later, so basically a patient that has recurrent venous thromboembolism. Okay, so you don't keep treating such a patient. You need to ask yourself, what is predisposing this patient to this? And you have ruled out all the acquired factors. So it's now time to screen that patient for inherited hemophilia. Again, we don't have this. Lab does it was 3 weeks. Okay, so you need to screen the patient for a factor V laden mutation, protein gene abnormalities, protein C, protein. Those facilities are not available in country. And we see this, you know, what you don't look for, you don't see. I have several patients with recurrent DVTs that have inherited hemophilia, established, you know, so it's important, I don't know, again.
How long renal anesthetics?
Renal anesthetics, I think they take
2 weeks.
3 weeks. And you know, it's a long time. I mean, waiting 3 weeks to make a diagnosis, I don't think it's ideal. These are diagnoses that should be made 48, 72 hours. Okay, right. Because okay, I'll give a typical example. I had this young man, 36-year-old, history of sudden death in 3 first-degree relatives, mother, father, elder sister, within 1 year. He had a history of a VTE. Sorry, my throat gets dry. He had a history of a left DVT in 2019, and then he had been treated. Okay, he had another DVT in 2020, and the person just treated him again without taking into consideration this guy's family history. I mean, if I see somebody that has a history of sudden death in 3 first-degree relatives, and you're coming to me with it, the first thing I will do is let me screen you to be you understand. Between 2019 and COVID was 2020. Between 2019 and 2022, we had 3 separate DVTs. And it's not like it was one continuous. He had imaging to show that first time he had a Doppler, there was a clot, he was treated, 3 months, repeat Doppler, clot. So he kept all the reports. And so I was just wondering that for such a patient, the first thing that you should have done. So when this patient came to us, he was breathless, he was basically fainting, neck swelling. We did a CTK, he had an acute pulmonary embolism. Doppler, he has an acute left, no, this is right. He has an acute right DVT. He has a sub-acute left DVT. And we screened him, inherited, he has LA, lupus antibodies. And so for that kind of patient, you're going to be doing what? Lifelong anticoagulant. But he's a very lucky man, he could have actually died. This should have been picked up in 2019. After he had the second, in fact for me, if he had come to me with the first one, without family history, it's always better to err on the side of caution. I would have just screened him for inherited hemophilia. Again, so these are the reasons why we need these diagnostics in country. Not sending it to Germany and South Africa and India. So again, not readily available. They are expensive. I mean, doing inherited hemophilia screening is expensive, but there are reasons why you want to do, why you want to screen a patient for inherited hemophilia, and one of that is unexplained recurrent VTE. Okay, so treatment of course depends on the cause. This is treatment of bleeding disorders now. Depends on the cause, platelet transfusion, blood and blood products, coagulation factor replacement. Yeah, I think. So the role of diagnosis in the management, we need to have a very high index of suspicion, like we said. A lot of times, the the symptom can be very, very non-specific. Okay, very non-specific. And so if you do not, what you do not look for, you will not find. Okay, so we need to have very high index of the screening tests are readily available. So turnaround time to do a PT in same lab will be what? Postponing time. That's what I do. Less than 24 hours.
I know it's shorter than that actually.
It should be like 2 hours.
I think it's less than 2. It's less than 2 hours. It's less than 2 hours.
Does anybody else here work in a lab? So what's the turnaround time for postponing time? 2 hours. 2 hours. Okay, so that's okay. So the screening test should be readily available. Early diagnosis, accurate diagnosis will lead to better outcomes, and then most importantly, more awareness. There are some people you be telling clots they don't have the focus, they've never heard of blood clot, so there needs to be more awareness on this disorders. Thank you.
Wow.
Thank you, Prof, for that detailed presentation. So because Prof will be going away, I would like to take our questions now. So please, the floor is open for questions.
Everything was understood, nothing was understood.
Something in between.
It's or something in between, or we need to go and turn it around in our brain. But was it a useful presentation?
Yes.
Was it enlightening? So that's very important. Not everybody likes to ask questions.
So, any questions?
Everything understood. You have a question? She has a
Just the minor.
okay, that's right.
You talked about independent
Antibodies, yeah.
So are you trying to say we should actually have a very alongside just in case?
No, it's not routine. But what I'm saying is, usually I expect that if you have a patient that you've done a regular food count for, and the platelet count is good, that you bring him to my clinic. So it's left to be the hematologist to tell me, who will pay for the extra one? It's not routine. But I just try to explain some of the reasons you could have a false prognosis.
Question?
Thank you for this wonderful presentation. I would like to find out for non-symptomatic patient at what age can it be detected?
And what is detected?
Yes, haemostatic disorder.
Which? Okay, is it DVT? So DVT has no age restriction. No. It has no age restriction. I've seen a 4-year-old that had an a central line pudding that came down with a DVT. So what I'm saying is clinical index of suspicion. Unfortunately, it's not all of them that you can pick. That's unfortunate because we've had patients that have come in, they've been, 1 minute they are well, the next minute they collapsed. And when you investigate, you see that they've had a massive pulmonary embolism. It's not, you cannot 100%, unfortunately. But what I'm saying is that when you're faced with such patients, if they have that luxury of time to present in your clinic, they should have very high index of suspicion.
And secondly, from your experience in Nigeria, have there drugs used by anti-hypertensive patients commonly, let me say, that are attributed to this disorder?
Drugs? No. No.
It's more about the disease. The hypertension itself.
It's the hypertension that can predispose to arterial thrombosis, not the drugs consumed.
Prof, please, where is your clinic?
Last week, sir. I'm a civil servant. Okay, you need my applause. I'm a civil servant. Last week, sir.
Thank you very much, Prof. But I can think, I think I can.
Okay.
Go on. Thank you for this presentation. Two things that I want to highlight. Education is very, very key. And the Haematology Society and us have a lot to do in educating our both clinical community and even the general public on these issues. Because slump and die issue is becoming very, very scary. And as you said, men is a risk factor. And you see, it's common with men that they will just sleep and not work. So I want to ask you now to collaborate with us in the Haematology Society to create a program that will educate the public on these cases and how to go about it, even if it is like create a social responsibility arm of our work to educate people. Thank you very much.
So in response to that, I know that the Nigerian Society of Haematology and Blood Transfusion, so a lot of these diseases have days of celebration. So even though education is something that should be ongoing and but I know that World Haemostasis Day is December, sometimes it's November, December. So the society usually does webinars, seminars, and all. October, and so the society usually does a lot of public education awareness. But like I said, one day in a year is really not enough. Okay? So even as we live here, let us all become ambassadors in our little corners, wherever we function.
Once again, thank you, Prof. Mine is more or less like the way forward. Okay, since the detection or this diagnosis could be missed easily, what is your advice? Can we introduce this? Could it be a form of routine test? Someone can just go and say, I want to screen for DVT, risk of having this or all of that. So when the one starts suspecting, not for me, I don't think it should necessarily be when someone is already down. So at what time, like me now, at what time should I say, okay, this time I have to go and screen myself to know, whether I'm at risk or not?
Okay, so I know that in the past, right? Okay, the first thing we usually encourage is do your yearly health checks. However, I know that in the past, what the easiest test to do would be a D-dimer. But like we said before, a D-dimer, even though it's very sensitive, is not very specific. And then when we talk about screening, especially population screening, unfortunately, a lot of factors come to play. Number one would be the cost. How much would it cost for you to be screening yourself for DVT and pulmonary embolism every year? Because if you really want to screen yourself for DVT and pulmonary embolism, that means every year you are doing your D-dimer, you're doing your venous Doppler or bootlet, and then you are doing your CTP. I have a few patients that do that on their own, yes, but it's not routine, especially if there is no risk factor. For those that have an identified risk factor, then they can toe that path. But if you do not have a risk factor, because whatever test you're doing, you want to weigh the risks and benefits. You're doing a CTP, you're exposing yourself to radiation. Is that radiation necessary? So in the end, those are questions that only you can answer. But I don't think is there any organization that does their routine screening and they add a D-dimer, Doppler? Okay, you can add ultrasensitive CR, okay. Well, it's
difficult to screen for small.
It's difficult to
It's a
screen.
general problem.
Yeah, it's
There are
difficult
many
to screen.
diseases, but there must be a reason why you are
Why
screening.
you are so because
Take for example now, if you live in Japan, because gastric cancer with big in there, they have same program for screening gastric. That is one disease. You have to demonstrate that this is of public
health importance.
importance. You have to demonstrate that you can do something about it. You are always screening a disease that has a pre-malignant, a pre-treatment form of. There's no point picking a disease if you cannot.
Because there are so
treat.
many diseases.
All right. So for this, the best bet is to say if you have a risk factor for DVT, then it will be important to screen. Take for example, somebody in my family has DVT, or I have had DVT before 2 years ago, personal history. Certainly, I have a higher risk than the next person. So it will be important for me to specifically screen for that particular disease.
Exactly.
You can screen for DVT, that does not mean that you cannot go down and go for DVT.
And something else will
Something
happen.
else. Are you going to
So
screen
there are
for?
so many I just think that
Be careful. Important thing is now is to now for resources, but there's a risk factor for this, then that's an indicator for us to screen in that particular segment.
And I also think adopting healthy lifestyle.
Exactly. To reduce your acquired risk.
Acquired risk. If you are going on a long distance journey, you might need to stop at some point, stretch your legs, take enough water. That's also helps because I think one artist like that had a Goldie or something, on the plane from America 12 hours. So while in the plane, take a lot of water, restrict alcohol intake. Those also help to reduce your risk, even if you have a risk that you don't know. Take a lot of water, reduce alcohol intake, cigarettes, anything that can predispose you to hypercoagulability.
Yeah, so what she said is very important because if you remember when we were talking about the risk factors, there are the acquired ones and there are the inherited ones. Unfortunately, you may not know the inherited one you have, but the acquired one that you can identify in yourself. I know that the presence of one risk factor doesn't mean you will come down with the disease. A lot of times, these risk factors may be compounded. So if you are able to reduce your risk by addressing the acquired risk factors, then you reduce your overall risk of getting into disease.
Thank you so
Sorry,
much.
I'm so sorry. I need to rush out.
That's fine.
Another engagement.
Thank you. So that was a very wonderful session. Should we continue with another presentation because I've been told the tea break is ready? Or should we have the tea break and come back? I want to try it.
Personal opinion.
We have the tea break?
Personal opinion.
Yes. Tea break, yes.
One more.
Let's go and stretch our legs.
That sounds right.
Okay. So the tea break is in the restaurant downstairs.
Okay, so for we that are fasting,
Oh, we will pack it. We will pack it. Yes. Even the lunch is packed as well.
just asking.
Yes, that's right. We're going to stretch our legs. Dr. West.